Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barella. Today's program is going to be interesting. We are going to talk about women's health. We're going to talk about some of the things that happen that are special for women versus us men. And to do this, we have a special guest today, Dr. Pat Connelly, an obstetrician gynecologist from here in Show Low. He's been here approximately 10 years, but actually has been in practice for almost 30 years. So he is our local expert, and I'll say welcome to you, Pat.
Thanks. It's an honor to be here.
It is an honor to be here because we're going to have some fun today. And, you know, women's health over the years has been a little bit different than men's health, obviously because they have the ability to have babies that us men don't have. But through the years, doing well care for adult women has been a lot different than, for example, for men. And so this has generally been termed the well woman exam through the years. And so what is a well woman's exam and why is it so special?
Well, I think over the years, women's health has evolved dramatically. When I first started practice, it was recommended that we start seeing young ladies as early as age 16 for evaluations. But it really didn't add any long-term value to a woman's health by doing that. So we really backed off to starting our initial exam for women, assuming that they're well, of course, at around age 21 now. And the reason for doing exams, I think, has multiple different aspects to it. The number one on my list is probably to troubleshoot life issues. I feel like I've had enough years of experience that maybe I can pick up on some things that young ladies and adult women and mature women really have to deal with and help them transition through life into new aspects of their life. Unfortunately, we don't always have a lot of time to do that, but that's an important part of it. Of course, the clinical side is to troubleshoot health issues, and for women, probably the number 1 and 2 health issues are breast issues and cervical issues, breast cancer and cervical cancer, and of course the multitude of things in between.
And I mean, broader life issues than just the clinical.
Yeah.
I mean, women's issues are, I guess, a lot different than men's issues. Psychosocial issues, dealing with sexuality, I mean, dealing with pressures of society.
Yeah, I think there's an awful lot of pressure put on women to raise families and often don't have a lot of support from society and or from their partners, especially as relationships have deteriorated over the years. For a lot of couples don't stay together and we end up with a lot of single parents. So we do spend a fair amount of time trying to help them along the way, trying to get them towards resources that might help.
Might help them and stuff.
And so if they don't come in for annual exams, we don't really have a chance to find out if something needs an intervention.
And you lose those opportunities. But mostly the serious things are related to the clinical issues. And, you know, we talk about women coming in for clinical exams, and almost always it's the dreaded pap smear test. And so what is a pap smear and why is it important?
Well, a pap smear was initially developed, was it the 45 or 46?
In the 40s is when
Dr. Papanicolaou was the one that discovered the ability to diagnose cervical cancer before it was metastatic. And that's where the pap smear was originally developed. Since that time, it's become much more sophisticated. We used to put a smear on a slide and stain it and look under a microscope. Now we use a liquid-based pap. And as a result, it's become much more sophisticated, much more sensitive, and much more specific. So that we probably spend very little time nowadays worrying about cervical cancer because we can diagnose at least a half a dozen things off a standard pap smear, including all of the sexually transmitted diseases. So it is an advantage that way, that if you get a screening for a PAP, you also get value added, if you will, for all of those other things.
Now, those things you're talking about, of course, when you talk about metastatic, it means you want to pick up the cancer before it's spread to the rest of the body. But all of these things seem to be, that you're describing, are things that the patient may not know about. For example, cervical cancer many times is present when the patient doesn't know about it. Is that true?
Yeah, I think that cervical cancer is often present for even 2 or more years before you might know about it. Typically, in the old days, before we had decent technology, you would diagnose it from chronic pelvic pain in a mass. Nowadays, we really should expect cervical cancer to be able to be eradicated if we could just get people in the loop, get PAPs done, but also prevention is becoming more profound as we get better vaccinations for the main cause of cervical cancer is HPV.
Yeah, and we'll talk about that in a second. In a second here.
But the PAP basically gets you in the door, and then I feel like that's an important part of the whole thing. But getting you there also makes a difference in just trying to help about life,
And screening for Pap smears starts at 21?
21, yeah.
Did you say?
Yeah.
And how often should a woman come in for Pap smears?
Well, with the newer PAPs, we've been able to space out the intervals considerably. Your first PAP should be 21, and then we'd like to do another one probably within a year to be sure we got it right. Then you could start having a longer interval if you're low risk and nothing is going on in other aspects of your life. You might be able to go as long as 2 or 3 years before the next Pap smear. But the debate is going on as to whether you should have a visit beyond a Pap on a yearly basis. That's where the controversy is right now, I think.
Well, when I was
because the Pap is just a technical part of the exam and not necessarily the whole exam.
The whole exam. So it's more than just doing a Pap smear. You actually have to, there's other physical things that you guys do.
Well, we like to think that we talk to people a little bit.
Well, I was reading some of the recommendations, and they say that after 30, they can continue with Pap smears every 3 years, but then they add the possibility of going every 5 years if you add an HPV test to the Pap smear.
Yeah, HPV is a virus that appears to be necessary to create the environment for cervical cancer. As far as we've been able to prove with all of the studies going back many, many years into the 50s and 60s, when they go back and look at old cervical cancers, all of them now are shown to have HPV. So I don't think you can get cervical cancer without HPV.
Well, that's interesting.
That's pretty strong evidence. And when you look at, nuns that were celibate throughout life, unless I've missed the recent literature, there's never been a cervical cancer case.
Yeah, I certainly haven't read any studies to show that. And so when they look at cervical cancer statistics, is it true that many of the people that have advanced cervical cancer have really been people that have missed their routine Pap smears along the way or never gotten a Pap smear?
I think in my practice, the only advanced cervical cancers I've ever found were women who went many years without a Pap or without an exam of any sort because they just didn't think they needed them.
Okay, so the first thing we can establish in this program is that getting a Pap smear and getting your well woman exam is very important for
very important.
So let's talk a little bit about HPV. You said it was, I think it's human papilloma virus.
Correct.
And from what you just said, it is the precursor or one of the stimulants for developing cervical cancer. So how do you get HPV?
Well, I have to say the vast majority of HPV cases are probably sexually transmitted. But the problem with HPV is it's almost completely asymptomatic. Many, many years ago when HPV was first discovered, it was found to be in warts, and there's probably 600, maybe 1,000 different strains of HPV. But the ones that we are worried about are the ones that don't show up. And there may be as much as 80 to 100 different strains that might be associated with cervical changes, cervical skin changes, or precancers and or cervical cancer. And that's the problem, is that partners may be very honest, but they don't always know that they have been exposed or have HPV as a carrier state until it turns up finally on a pap smear. The men are often asymptomatic too. They don't always get condyloma or warts on the genitals like they used to. These strains have changed.
Wow. So you really, most of the time, from getting what you're saying, you can't tell you got it.
That's exactly
unless
correct.
somebody tests for it.
That is exactly correct.
And
now the PAPs do that automatically. In our office, we do PAP with HPV every time. And actually the push now is not to even do a, quote, PAP, but do a cervical HPV screen for the high-risk strains. And if they're there, then they do the PAP on the same specimen. And if they're not there, they don't do anything further.
And that's really a technology advance that allows that now, because
yeah.
in the old days you couldn't test for it easily.
No, it was nearly impossible.
Yeah, the new DNA testing is something that's beyond us, but they apparently do it, and you can just send it off to the lab.
Yeah, you can get a whole printout of all the different strains. And the only question then is sampling error. How do you know that you did a good enough PAP to know you either found it or it's not there? And that's why you have to have them more than once.
So how many of, let's say, for example, in your experience, how many people do you screen for HPV don't have it?
Oh, I don't know. That's a tough number because I don't really keep track.
But do you see it?
I would say that it's very prevalent. I think some estimates say as much as 60% of the population has been exposed.
So that's a lot.
It
so
is
eventually,
and worldwide, it's not just the U.S., it's worldwide in all populations. There's no picking and choosing amongst the races, so to speak. It's out there for anybody to.
So some people have claimed that if you only have one sexual partner during your life, your chances of having HPV are extremely, extremely low.
I'd have to agree with that, but it depends on what else the partners did before that relationship. In other words, if they were both single partners, I'd have to say that the chances of HPV and cervical cancer should be near zero.
So monogamous for life
Yeah.
people have a low
that's
incidence.
I think that's a good.
That's one solution.
It is.
But your comment earlier is that
What about
society is different right now. So if you have HPV, how do you treat it?
You really can't treat it other than being a healthy individual with good immune system. And smoking, of course, decreases your immune response. So there's much more cervical cancer and precancers and HPV outbreaks in people who smoke. I can't really speak to whether marijuana smoking does the same thing. It has to do with the tars and cigarettes.
Okay.
That's probably the biggest risk factor for advancing with bad PAPs is smoking.
Okay. So if it can't be treated, can it be prevented?
Yes, it can. Obviously, using condoms and safe sex practices is essential, but in monogamous relationships, that may not be something you really need to do. Therefore, our children really have the opportunity to prevent HPV. There are several different vaccinations available. Probably the most famous now is Gardasil, which treats 4 strains of HPV. There's research on 3 strains, 2 strains, see if you need, et cetera, et cetera. Long story short, if we could vaccinate men and women, girls and boys, prior to their exposure to HPV, we could potentially eradicate cervical cancer from the world, and HPV from the world, possibly.
So Gardasil or the other HPV vaccines are given to 11-year-olds to 13-year-olds, is that I think that's
I
the
think it's a good
recommendation.
estimate. Yeah, 11 to 13 prior to sexual
Prior to
contact.
sexual activities. And in some sections of the world, a significant portion of the children are sexually active at 14 to 16.
Yes.
And so it's really important to get there before they even start. I know there's been a lot of controversy in the United States and reluctance among parents willing to give their kids Gardasil because it thinks it allows them to be sexually active and not have to worry. But that's
Yeah,
not true, is it?
I don't think there's ever been any real evidence to support that. I think the same belief was prominent with the development of the birth control pill, saying if you could prevent pregnancy, everybody would become promiscuous, and it really didn't happen.
That a great analogy.
And, in fact, the first pregnancy in unprotected teens is usually the first encounter, not the second, third, or 100th encounter. It's the very first act of intercourse that leads to that pregnancy. I think that's a profound number right there. So if you really wanted to protect your kids, a bit of a philosophical and religious issue, but if you just looked at it medically, you would protect your kids before they became sexually active. And I think that's powerful with HPV. So.
Yeah, they'd only tell us ahead of time that they were going to be sexually active.
And that's the failing of us as parents, is we didn't allow that conversation to occur.
That's a very good point, especially for some of the things that you interact with. Sometimes we as parents could do a better job of being involved with our children's lives, but that's a different issue. That's teenagers is a different issue.
Show.
that's an entire show among itself. It's interesting when you look at cervical cancer deaths that there's, they say there's about 35,000 in the United States a year, and a significant number of those are in men. So, and men don't ever, as far as I know, get screened for HPV.
It's not an easy screening. I'm not sure. Not treating men, I don't know what process there is for that, but I don't think it's very good. There's no blood test really because the antibodies are unreliable.
Oh, is that okay?
Yeah, I mean, even if you were exposed, it's just like herpes simplex. The antibodies don't really tell you if you are infectious or asymptomatic viral shedding.
In other words, whether you have an active infection.
Yeah,
or not. Okay.
Yeah, it really isn't very useful. So.
Okay, so in terms of finishing with women care, the other half of this is mammograms. Women are advised to have mammograms, and those recommendations have changed through the years too. Have they not?
They have. I think the U.S. has been very, very aggressive at screening with mammography, trying to reduce breast cancer in this country. And so we originally started with a 35-year-old baseline, and then the idea was you'd have something to go on when women turned 40 and got their first diagnostic mammogram. Really didn't pan out because there's so many physical changes between 35 and 40 in the way the breast glands, characteristics, everything, that those mammograms were pretty useless. So those have been dropped. And then we went to screening every year at 40 because about 20% of all breast cancers do occur in the 40s. But those are also very slow. Many of them, vast majority of them, are very slow growing. Right. So when you look at the actual outcomes, screening every year at 40 really didn't reduce breast cancer deaths. What it might do is give you more options for treatment if it's not so advanced. And that's a big deal in the U.S. to be able to consider a lumpectomy and maybe very little chemo, very little radiation. So that's probably the big push to keep doing them frequently, is to try to catch them early. But actual outcomes really don't change that much if you go every other year. So much of the world really says start mammograms at 45 and do them every other year, and then at 50 do them annually. The push is coming here to do that because I think we're becoming more and more comfortable with the idea that we can catch these things early enough that we give all the options women want, plus good outcomes. And less radiation, less cost, and less discomfort, because let's face it, mammograms kind of stink.
Never had one, but my wife
I
tells
don't
me that
get
it's
too
not a
many.
pleasure,
I don't give it too many reports that they want to get an extra one.
that they enjoy that part of their life.
Yeah.
As two
But
men
they
sitting
are
here talking
essential.
about women, that will just
They are definitely essential, and I would hope that women would not avoid them just because of some discomfort that only lasts a few minutes.
a very good point. You know, it's interesting in talking about these two topics, mammography and will women exams. A lot of what you do is prevention for cancer and serious problems that it can affect women for life.
Yeah, I think so, and I think that's been one of the prominent things that OBGYNs have done. You know, our country isn't really motivated to prevention. They're more reactionary treatments to a lot of these things, but cervical cancer and breast cancer are so devastating that prevention really is the key there.
Okay. And I certainly, and it's certainly the other half of the enjoyable part of delivering babies and bringing new life in the world. Let's go on, and one other area that's really important that you as a GYN get involved with is menopause. And the recommendations and advice for women on menopause seems to be changing for maybe the same reason that you talk about more data, more information available to the general public.
Yeah, it's been quite a controversial topic in how to manage menopausal symptoms, and women now spend nearly half their life after menopause with the increased lifespan. You know, average length of life for women is 88, I believe.
It's in the 80s.
And it may be approaching 90 because women are taking better care of themselves than ever. So average menopause used to be anywhere from about 48 to 52, but I've seen it over the years extending more and more commonly out to 55 or even 58. And so women are cycling longer, have to deal with that more, and yet the periods can be very difficult to manage when you approach menopause. So a big part of our practice is trying to survive those years and keep a level, balanced outlook on life when you're going through those struggles. And that goes back to hormone replacement. That has come full circle too. When I started practice, it was almost automatic around the time of menopause to start hormone replacement. That's estrogen, progesterone, try to balance out symptoms and maintain healthy tissues and in a variety of things, including osteoporosis.
So does that mean that the cause of menopause, or one of the things that happens in menopause, is that women essentially lose their ability to make some of these hormones? Or the cycling is different?
The definition of menopause is absence of eggs. Basically, the ovaries have run out of eggs, and therefore the cycles stop because the egg sacs and release of eggs drives the whole process of building up an endometrial lining that then sheds every month, which is what the menses or the period is all about.
Okay.
And so when that happens, the levels go very low and very even. They still cycle every month, but at a very low level, subovulatory. And so symptoms of estrogen withdrawal can be profound.
So what is the recommendation for women now, post-menopausal, at whatever age it starts? Do we do hormone replacement, or is there a downside of that?
Well, in 2000, there was a very major study called the Women's Health Initiative, and it really sort of questioned whether hormone replacement was valid, safe, and effective. And as a result, many physicians pulled back and withdrew hormone replacement at the time of menopause. And I think it really needs, instead of just pulling back, you need to have a conversation about whether you're a good candidate, whether it would be of value, and also balance the risks, because I don't think anyone would argue that taking hormone replacement long enough increases your risk of breast cancer.
So that's the downside, is breast cancer.
That is the downside, but the numbers are small for any one individual. I think the big problem is the population. If you increase a risk of breast cancer 1 per 1,000 and you have 80 million women on hormone replacement, that's a lot more breast cancer in our population.
Ah, I see.
But each one individual has a very low risk, but you need to manage the risk. And so I've taken the approach that here's risk A and here's risk B, which is to suffer during menopause and have all of the symptoms of menopause, including night sweats, insomnia, emotional ups and downs, all of the things that are very uncomfortable, and including painful intercourse from dryness, changes in the tissue, changing of bladder function. We could go on for an hour just with all the negatives.
All the potential symptoms.
And the fact that you're going to spend half your life like that, that can be a big impact. So to me, I try to balance the risk and the benefit and say, you are suffering, you maybe should consider hormone replacement. Many women fly right through. They don't have any of those troubles. And I would say, well, maybe you don't really need those right now, but you might down the line. So you really have to have the conversation. And that gets back to the well woman visit.
Yes. More than just a pelvic exam. Wow.
Exactly.
Okay. And it sounds like, it sounds like, again, cancer is a big risk, but also the lifestyle that you have to live with every day is the offset.
Well, and hormone replacement can help with bone health. And if you look at breast cancer death rates, they're lower than the death rate from a fractured hip from osteoporosis. So to me, I'd rather treat bones and keep people moving and healthy and worry about catching a breast cancer early with mammograms than I would ever want to have someone suffer from a hip fracture.
And that's why it's so neat to have well care. One thing that we've talked about today is that, at least in women's health, prevention is a very big part of their life.
I think so.
And as your comment earlier about, preventing or getting cancers early enough by doing routine pap smears and stuff is important. So if women get anything out of this today, it's that they need their well women examinations and good follow-up. And I thank you for being on our program today, Dr. Connelly. And I thank you for watching today. I hope that this has been a wonderful program for you. Thank you.